Hello, everybody. Thanks to join us. Today we are talking a little bit about one of the, for me, one of the most important segments that we have because it's very um, uh, satisfying rings for advanced cases. We have here today Dr. Pablo Morales. He's a great corneal cataract and refractive surgery specialist. He's actually working in Spain right now. He's at the Instituto Clínico Quirúrgico de Oftalmología in Bilbao. Hello, Dr. Pablo. And
Hello, good
hello,
afternoon.
thank you. Thank you for being here today with us to share your great experience with these rings. You studied, I'm just to introduce you quickly. You studied in Chile, you are from Chile. You also did your specialization in here in Barcelona, in Spain, and you did the fellowships for 3 years in Canada and other experience in UK, but everything always oriented in Korea, right?
Yeah, well, thank you, SofIa, for this invitation. Thanks, AJL, for the invitation. For me, it's a pleasure to be here. We've been working with these cases the last 3 years, and we're having lots of interesting results. So yeah, my main experience is in cornea, and especially in the last 3, 4 years, it's been keratoconus. And being from Chile, one of the things that I've been moving around a bit. So when I came back to Chile 2 years ago, I started seeing very advanced keratoconus, and that's the reason why we're here today. Basically sharing my experience that we have with these segments that sometimes we can get like really nice surprises.
Yes, exactly. When we start to think about doing a webinar in intracorneal rings segments, uh, I was thinking about a nice, interesting topic. And for
Mm,
me, these rings, the 320, it's really, really very, very important. And I feel like we need to transmit the great results that we can achieve with these rings. And
mm,
that is not that difficult. So we can really, I know that new surgeons are afraid about the technique, the actual surgery, but
mm.
they shouldn't. And so that's why we start to talk with you, and we are here so you can present some cases, we can present some results, and something about the techniques to help the beginners who doesn't have many experience with this. Please, during the presentation, you can make a right question. So I will transmit it to the doctors, and we can talk. We plan to do just 30 minutes to be like very effective, short, and effective on this topic. We really appreciate some question from your side. Doctor, if you want to start, I think
Yeah, of course.
we can.
Okay. So again, thank you for this invitation. Thanks, Sofia, for organizing this. I think we met a year ago, and the first time we met, we already were talking about the 320 ICRS. So, well, we're gonna start with a few cases. So this is the one case that I had a few years ago. 28-year-old man, first visit ever to the ophthalmologist. So he thought that he was seeing a little bit bad with his vision. And we see here that the vision is really poor, uncorrected, and best corrected. Of course, it's very hard to get a proper and reliable refraction in these cases because they are very advanced keratoconus. But because when we did a topography, we have this result. It's a typical bow tie phenotype with high keratometry readings, high hyperprolate cornea, and high astigmatism. We don't know the situation before, and we don't know if this patient is stable or not. Of course, we know that the rings won't stabilize the keratoconus, but this is something that we have to discuss with the patient if it's stable or not. We might as well do a cross-linking right away, or maybe with the procedure. That's something that it's talked to with the patient. Or in this case, we just decided to go because of the age and the vision. We wanted to improve the vision the most quick as possible. We decided to go for the ICRS, the 320 ICRS, according to the AJL nomogram. We see here a super interesting result. It was really surprising for me and for the patient as well. First day after the surgery, the patient was already seeing 0.8 at 3 months. The vision remains stable. The reason of that huge improvement is because of the improvement in the astigmatism. So we know that all these 320 ICRS will flatten the cornea. As we see here, we see a huge flattening of up to 7 diopters in the central keratometry, plus there is a huge decrease in the astigmatism, and the correction of the sphericity of the cornea. There is an improvement in the prolateness from minus 1.2 basically up to minus 0.6. That means a 50% of improvement in the sphericity, and that explains the vision. So this was a very interesting case. And there's another case that here we're going to present. This is a 22-year-old patient that was directly referred for PK in both eyes. Vision was really poor, 0.1, 0.2. With a contact lens fitting, a scleral lens, we just get to the 0.4, 0.5. Of course, that's something that we have to discuss with the patient. There's a possibility that the patient will end up with a transplant anyway. All these cases were seen in Chile, where in Chile we don't have much availabilities of corneas. We have to, most of the times, import the corneas from the States, which makes it more of a hassle. Plus, it's much more expensive. So it's something that we have to talk with these patients, the possibility to do an ICRS, and because there's no scarring, and we see the topography, typical phenotype of a nipple phenotype, high keratometry readings, high hyperprolic cornea, minus 1.35 of the Q value, and not very high astigmatism as opposed to the bow tie. This is the right eye and the left eye. So the left eye is a little bit more advanced. And according to the nomogram, we decided to go for a 320. We see here that in the left eye, it's a little bit more thicker. The reason of that is because it's a little bit more advanced. 1 month after the surgery, we're seeing the vision uncorrected is 0.4, which is basically what he was seeing with the contact lenses before the surgery. And this is really important because the patient, from being 0.2 and relying on a contact lens in order to see, in order to live, the patient is already doing more normal life, and with a contact lens fitting after, the patient is almost getting 20/30, 20/25 vision. And the patient doesn't rely on a contact lens. We know that the contact lenses, clear contact lenses, if you lose them, if they break, you have to order them, you have to get another fit, it's expensive. So it's not a matter of just losing a contact lens, it's a matter of if you lose it, at least you can still have some vision, like more functional vision. So we see here similar results. The right eye, we see a flattening of up to 7 diopters. In the left eye, because it's more advanced, and that's something we're going to discuss later. The more advanced the keratoconus it is, the more flattening effect that we're getting. And in this case, the left eye, we're getting flattening effect of up to 7.5 diopters in the left eye. And this is another case that we're gonna discuss. This is a more advanced case. A 36-year-old patient was referred again directly for PK. We see that the vision is very poor, counting fingers both eyes. The left eye, there's nothing we can do. It has to go for a transplant because there is no improvement with the contact lens. But in the right eye, even though the vision is really poor, we are able to get a 0.4. So the same discussion that we had with the patient, there's a possibility to maybe go for a transplant, but instead of having a bilateral transplant in a 36-year-old patient, might as well try it with the right eye. So the left eye is a very central dense apical scar, but in the right eye, I thought that glaucoma, which is very mild and subtle, is not affecting the vision. So the vision is more affected because of the irregularity instead of the opacity. So that's why I discussed it with the patient, and we decided to go for the ring. This is the topography, very hyperprolate cornea, minus 1.79 in the Q value, very high keratometry readings, up with mean keratometry readings up to 60 diopters. This patient's been stable. I did a transplant in the left eye because there was no other option, but in the right eye, we decided to go for the ICRS according to the nomogram. 1 month after the surgery, the vision is 0.1, and in the left eye as well, but with a contact lens, scleral contact lens, we're able to get 20/20. That's something really important because before the surgery, the patient was seeing 0.4 in the Snellen, the decimal 0.4 with the right eye with a contact lens. So it's not only that we're improving the uncorrected visual acuity, the best corrected visual acuity, we're improving by 6 or 7 lines. So again, the higher, the more advanced the keratoconus, the higher the keratometry readings, the higher the Q value, we're going to get a more flattening effect, as we see here. We see here that the effect is up to 10 diopters centrally flattening. So this is a
Doctor,
series
I'm gonna interrupt you 1 second, just
yeah.
because we finished the cases.
Yeah.
If there are any question about the cases, but I think I have a question, or maybe I think just exactly about this case 3. You told me that in the right eye where the glaucoma was inferior, after the ring, it was displaced even more.
Yeah.
I think it was this that you said that even if you have a reasonable glaucoma, you can, you can improve because it moves after rings.
Yeah, that's something really important because sometimes, especially when you're starting with rings and with these very advanced rings, you see the contraindications of a ring implantation. It's always like an apical scar, glaucoma, central glaucoma. But if it's subtle, of course, that's something that has to be seen in the slit lamp. But if it's subtle and if it's central or it's even if a little bit displaced inferior temporal, once you implant the ring, because there is such a flattening effect of the cornea, the glaucoma can displace a little bit. And even if the displacement is not that much, if the glaucoma is subtle and it's not the opacity that's affecting the vision, but the vision is affected for the irregularity, I think that there's no contraindication at all if it's between safe limits to implant the ring.
Okay, thank you. That was something that I think it's very important because, as you said, everywhere you read that glaucoma is a contraindication. But yes, if you have,
I think that the most important thing here is to discuss it with the patient preoperatively. Of course, we're not offering something that is completely. The patient has to know that there's a possibility to do a transplant, but this is a real option to at least delay the transplant. That's the main thing. And if the patient agrees, it's easy procedure. Well, something that we can discuss later, but it's no pain. The day after, there's already improvement, and with a very low rate of complications.
Yeah, also because, as you said, there are some countries where transplant is not that easy,
Exactly.
and in other countries is totally not an option because it's not
totally
it's not legal. So that's why I wanted to emphasize that it's really, really a good option this to consider.
Exactly.
Keep going with.
So according to this, so these are a few cases from this series that we have here. This is a series that I presented at this year's ICRS in Barcelona, and here I'm talking about just uncorrected visual acuity, and the main reason of that is because it's impossible. It was impossible, at least for us, to get a best corrected visual acuity because these patients were so advanced that it was impossible to refract them. And also, some of the patients were very difficult to adapt or fit a contact lens after because of the socioeconomic circumstances. So the patients, after the surgery, we lost them, we lost follow-up, but usually, according to that, we were able to get anyways uncorrected visual acuity at least 6 months for this series, which is 20 cases, and most of the cases, well, we didn't have any complications in this series. Most of the patients gained at least 3 lines of uncorrected visual acuity. As we see here, the mean uncorrected visual acuity improved in 2 to 3 lines. The asphericity, the prolateness of the cornea improved almost more than 50%, and all the topographic parameters improved drastically and significantly as well. And that's something that I mentioned before, the table in the bottom to the right, how the improvement in the astigmatism in the both eye phenotypes makes these patients really the results is really amazing, because it's not only you're flattening the cornea, it's not only you are improving the prolateness of the cornea, but also you are decreasing the astigmatism. And as we know, the astigmatism in the nipple phenotype is not a really significant thing. Of course, in the end, with a contact lens fitting, most of the cases we're going to get the same result, but in the bow tie, we're decreasing the astigmatism as well. So this patient get spontaneous, very good vision. This is a series that was published this year in 2024. No cases of complications, 320 ICRS, and it is 10 eyes, and very similar results to ours in terms of topographic improvement. And this is the largest series that have been published so far from the Torquete group, and this studied 138 eyes, doing both techniques, manual and femtosecond, and basically they're getting the same results as us. We see huge improvement in uncorrected, best corrected, asphericity, and something that I mentioned before in the bottom right table, we see that the more advanced the keratoconus, the more flattening effect we're gonna get. So, for example, for corneas over 60 diopters, we're going to get flattening effects of up to 8 diopters, which is the same that I showed before. This is another study published by Jose Alfonso. It's really interesting because sometimes, as SofIa mentioned, there's some belief that the 320 degrees is very hard to implant, and that's why the 300 degree ICRS was designed in order to facilitate and make the implantation easier. And they noticed that actually they have very good results in terms of similar topographic results in terms of flattening. Of course, we don't have comparison between 320 and 300. And one of the important things in this, and that's something that Torquete also mentioned, is that because the flattening effect of these rings is so big, that if you implant these rings in not very advanced cases, you can get overcorrections, and that means that the vision or the final result, the final outcome of the patient won't be as good. So basically, we have to save these cases, these rings, for advanced cases, and that's the reason why they're separating 2 groups over 0.5 or less than 0.5 in terms of best corrected visual acuity. So in conclusion, it's indicated for advanced keratoconus in order to delay or even prevent PK. For central phenotypes, according to the Jose Alfonso classification, especially in nipple and bow tie, in my experience, I think that the bow tie benefit the most in terms of uncorrected visual acuity, but in terms of final results, it's the same. Benefits, there's a significant improvement in the prolateness of the cornea. That means in the Q value. A Q value, it's a meaning of quality of vision. So the patient can be still needing a contact lens. And I've heard some patients telling me that after the surgery, even that they are still using a contact lens, the vision is much better than it was before the surgery with the contact lens. So we're getting quality of vision, and the reason of that is we're improving the shape and the prolateness of the cornea. Not only that, also that flattening effect makes the fitting of the contact lens, most of these cases is needed, easier. And in terms of complications, it's a low rate according to what has been published, according to my experience. My experience, I've only had one perforation. That was a case with a patient with no cooperative patient at all. I think that was the reason, because in terms of the intraoperative, because of manipulation of the ring, I never had any complications. I never had any case of migration or extrusion. And the reason of that is because there is a 20-degree gap from both ends in the 320. In the case of the 300, 40-degree gap, and that's not the case with the 355 or the 340, where there has been published more cases of complications in terms of migration and extrusion and perforation. The technique basically similar to a normal ICRS. I usually center it to the pupil. I do the incision superiorly. These are my parameters. I've been with another colleague. We've tried different parameters in terms of the tunnel dimensions, and we get to the conclusion that basically with an inner diameter of 4.7, 4.9, and an external diameter of 6.0, 6.1, that means a differential between 1.1 and 1.2 between both diameters. We get really easy implantation. I usually go 75% of the thinnest point of the implantation diameter. In terms of the manual technique, I don't have much experience actually. I've heard that with the vacuum pump, it's much easier.
Yes.
And
If you want
here.
Yes,
Yeah.
yes, yes. If you want, exactly. I know that you are more familiar with Fento, so thank you, because you suggest your the parameters that you prefer for the Fento, exactly about the manual technique. Yes, with vacuum pump, in generally, it's easier, it's better, it's more precise, and safer, because the risk of perforation are really lower. But also, especially for these such a long rings, you can create a better tunnel. So at the moment of the insertion, it's better. About the 300 arc, better for the manual technique is still the 320. Consider that the length of the spatula, that the dissector, which is 330 degrees. So in 300, we have more space to accommodate well the rings. And about the depth, it's well known that the depth for manual technique, it's the 80% of the pachymetry, pachymetry at the incision site. So the doctor has to measure the pachymetry intraoperatory, and calculate the 80% in that moment. I know that you are more for Fento. We have a question. It was actually what we point at the beginning about the center of the ring. We generally suggest to use a visual axis as the center of the ring, but as you mentioned, in such advanced cases, sometimes it could be not easy using the visual axis. So you said that most of the time you use the pupil, right?
Yeah, the reason of that is because we're getting very central flattening effect. So the more centered the ring is inserted, the better result we're gonna get. And sometimes in these cases with very advanced keratoconus, there could be some disalignment of the axis, but the pupil will never, unless you have an anisocoric pupil or some trauma in the pupil. But in normal life, usually centering in the pupil, it's enough to get a centered ring.
Okay, thank you. About another question about the incision, do you always use 90 degrees at 90 degrees the incision, or sometimes you make some changes in the position of incision?
Well, for nipple, yes, because in nipple cases, usually the protrusion of the cornea is very centrally. But in cases of bow tie, if the bow tie is not aligned at 90 degrees, maybe I can do it in the steepest axis, because usually this, even though there are irregular corneas, they're in the more regular side of the irregularity. So you can get a really significant axis, reliable axis in the topography, and sometimes I can do some changes in that, especially well for bow tie. But for nipple, I usually do it superiorly at 90 degrees.
Okay, thank you. There is,
So
yes, the part.
So yeah, the technique is basically the same. It's very important here because this is such a long segment that if you don't go perpendicular enough, it's very hard to implant it because the distal end touches the surface of the cornea when you are doing. So our natural tendency is to horizontalize a little bit earlier. So that's one of the main differences. So go very perpendicular until the end touches, or you find the bottom of the incision, and then you horizontalize. Once you horizontalize, you grasp before that, I use with the Suarez spacer. I go to both sides of the incision, to the right and to the left. And the reason of that is because once I start implanting the ring, once you are halfway through the tunnel, that's when the distal end starts touching with their inner diameter, the inner ring of the tunnel. So in that case, I usually very gently with the tip of my finger or with a forceps, I try to reorientate or redirect the distal end, but I try not to force and not to put that much stress over the cornea. So if I'm noticing that I'm struggling a little bit, I just take out the ring and then go to the other side. And on the other side, once you are already entered enough, because all the rest is already tunnelized, then it's really easy to implant the ring. So that would be my main tip for you. Go on one side, try not to fight. If it's struggling, then remove it and go to the other side. That's why I do with the Suarez spacer. I go both sides.
Okay, thank you. And it's not difficult at all.
No,
Just
at
be
all.
patient.
Actually, you know that my first ring was a 320 degree ring, because I was getting all these cases and I was really interested in starting doing ICRS, and my first 20 cases were 320. And once you are, and in terms of suturing, it's the same thing. The first cases I didn't feel very comfortable and secure, sure. So that's why I always place a suture. Plus, the first cases I was struggling a little bit more, so the incision was a bit more open. So I always place a suture. But right now I'm not placing a suture at all, because if there's not much manipulation, the incision will close by itself. So there's no need for suture. But if you want to place a suture, there's no problem. Just don't tight it very much, or else you are not getting the full result of the ring.
Yeah, this is something that most of the doctor told me, that at the beginning, they are probably more afraid and they put one stitch. But with the time, since the incision is always stay very clear, they just put the contact lenses on top, and that's it. And last topic, it's about how to calculate. You know that there is the AJL Nomogram. It's online and free, so you can do your own calculation. And about the 320 ring, every time the asphericity, so the Q value is above so more negative than minus 1.2, the nomogram will give you, will suggest it will suggest 320 rings in 5 millimeters. This is another question that we have from Alvi. Is asking how to choose the base. Is actually referring about the optic zone 5 and 6. I personally, most of the time, if there is any other reason, I always give suggest 5 millimeters optic zone. What about you? Have you ever used 6 millimeters in case of 320?
But I think that 320 is only 5 millimeters. There's no 6
No,
millimeters, no?
there is also in 6.
Ah, okay. No, I only use 5.
Okay, yes.
Yeah,
So
because
yes,
I want to have a more a more flattening effect. The more central I go, the more flattening effect I'll have. And if I want to decrease the astigmatism in case of a bow tie, the going for a 5 millimeters is better than going for a 6. So I'll get a better result. Always remember that all these cases are very advanced. So you want to go for the more flattening effect that you can. Always taking taking in mind that the asphericity is very high in this patient. So there's a study that I think it's from Turketis as well, that according to the thickness of the ring, how your asphericity will improve. And basically with a 250, you might get up to 0.6, 0.8 of asphericity correction. That's why the reason why the nomogram, the nomogram, the AJL suggests that over 0.1, 1.2, providing you a 320, but if it's less than that, maybe go very cautious with a 320.
Yes. So exists, just to point, the 320 exists in 6 millimeters. So it's in stock in AJL. But as you said, it makes sense to use the 5 millimeters. In my experience, happen some extreme cases where at 5 millimeters, the pachymetry is really, really too low to consider. So for some reason, you decide to go at 6 millimeters, or maybe you have any other issue why you need to think to another option, because with the 5 millimeters you cannot go. But yes, very, very, very special cases. Otherwise, that's why the nomogram is always give you 5 millimeter, because it's a central issue, the sphericity. So you need to stay closer to the center to have the better effect as these cases. So
And
yes.
again, this is really important what you're saying, SofIa, because as you mentioned before, over 1.2 will provide you a 320, but if it's less than that, the nomogram will provide you most likely a 210. So if you have an asphericity of 115 and very high keratometry readings, and the patient has really low vision, you might go as well for a 320. That's something that has to be customized according to the surgeon. Of course, the nomogram will provide you some guidelines, but in the end, it is the surgeon that has to customize the treatment according to the patient, according to the topography, and according to the discussion that you're having of the options that you have.
Exactly. You say it very well. Especially for these cases which are very advanced, very with very special parameters, the nomogram suggests you something, and most of the time it's really the best option, but you need to consider other things. So you have to optimize, and the surgeon needs to be confident with everything. That's why we have the professional support service, which is the Keratoconus at AJL-RING, where you can share your cases and we can discuss together. I also have sometimes some doubts. So Dr. Morales is always very kind with me, and we discuss some really extreme cases. So yes, you can share cases, and we try to help as much as we can. So because we had some question, but I saw that we answer slowly. Yes, what about okay? What about the halos for your patient? Do they ever complain about the halos that they can have during the night?
No, no, because, well, they do refer it, but these patients are really advanced. So they already have halos. The vision is
Yes, yes.
usually they're happy with the outcome. Of course, again, really important to tell the patient that most likely they will need a contact lens fitting. You are not promising something that, okay, you're gonna have this ring and that's it, your vision will be perfect. No, that's not the case. This is these are cases which most likely are gonna go for transplant. So basically, you are avoiding or at least delaying this. And if the patient understands that, and they see the improvement in the vision, they don't complain about halos. They are, but it's not an issue in these cases, at
Yes,
least in
yes.
my experience.
We that's why we have always to not forget that those are really advanced cases.
Mm,
So yes, everything like Alice for sure is the uh, less problem of the of the
mm,
patient.
mhm.
So that was the last. Can you change to the next one? Okay. So
Yep.
yes, we finish. You can download the presentation, so all you can see again all this data, the presentation. You can always email us for any further questions, and that's it. Thank you to Dr. Pablo to be here today. And hopefully, this is one of the many other appointments with rings together.
Okay, no, thank you, Sophia. Thank you for your passion about this topic, and it's really interesting for me to share all this experience and really to transmit that these cases we have to try it. That it's not a really big issue. The worst thing, the patient will end up in a transplant anyway. So these are really good outcomes, and you're gonna get it's really rewarding as a surgeon to have these cases.
Okay. Thank you so much. And that's it. We let you go.
Thank you very
So
much.
have a great day. And
You
thank you
too.
for everybody to join us.
Thanks
Bye.
for joining. Bye bye.
Bye bye.